Good afternoon, everyone. So we've got to the fourth session, which obviously Carl and I think is the most important session of all. We are just going to crack straight on with it and not really bother with a talk or introductions of many people, because all of our speakers are well known and some of them have spoken already. So first of all onto the stage, please do feel free to read her biography in the handout that you've got, but we'd like to invite Professor Emma Clark up to the stage. Thank you very much indeed.
Hello, everybody. I've been told to say pronoun thou, terrible Welsh accent. So you don't even know what I've said, do you? So I've been asked to speak about vertebral fragility fractures and who to X-ray, which I think directly answers a question that was asked earlier. Here are my disclosures today, which have no bearing on what I'm going to say. But I think it's important to point out that I'm actually a trustee of the Royal Osteoporosis Society, and I'm chair of their Clinical and Research Committee. So, just to remind you why it's so important to identify people with vertebral fractures. We know if somebody's had a vertebral fracture, they have a 25% chance of having another vertebral fracture and a 10% chance of having a limb fracture within 5 years. And we have medications available that can reduce that by half. But we also know that people with vertebral fractures have a reduced health-related quality of life, which is mainly due to reduction in physical functioning, suggesting we can intervene to help. And this reduction is worse than after a hip fracture. So, despite that, at least less than a third, I think probably about 20% of people with vertebral fractures are appropriately identified and managed. And the bottom line is, to find the vertebral fracture, you've got to do a spinal imaging, a plain X-ray, an MR, whatever it is. You can't diagnose it without a spinal X-ray. So, a major problem is there was a piece of nice guidance about how to manage and investigate young people with low back pain. And the first bullet point in the summary document is do not X-ray. And that has spread out to involve, or to mean, I think, that if anyone at the moment really goes to a healthcare professional with back pain, you have to fight to get an X-ray. So I'm now going to go through features of the history and examination to convince you that we can actually decide, we can use evidence to decide who to do an X-ray on. And then I'm going to talk about how we can combine those, which is my main piece of research for the last 10 to 15 years. So let's start with pain. There is an urban myth that vertebral fractures are painless, that they're clinically, that they are silent. And they're not actually. And some of the best evidence for that is from the study of osteoporotic fractures, which is quite an old study now, but they took just over 7,000 white women and X-rayed them at baseline and then X-rayed them again 4 years later. And during that time, a proportion had vertebral fractures but didn't know they had them. They hadn't presented to healthcare. Nobody knew, but nonetheless, despite they didn't know they got a fracture, they reported an increase in back pain and a reduction in their ability to do their activities of daily living. So vertebral fractures are painful. It may not be that bad after some time, but they're still painful. So we've done some work that shows the site of pain is different in people with vertebral fractures than those without, and particularly lateral waist area pain is associated with an increased risk of vertebral fractures. We've also done some work where we've looked at the description of pain. So we've taken people who've had a spinal X-ray in the last 4 months, and we've then sent them something called the McGill Pain Questionnaire, which asks all sorts of things about their type of pain. And we know that those people who have vertebral fractures describe different pain to those without vertebral fractures. Those without vertebral fractures, mainly degenerative, osteophytes, loss of disc height. And they describe the fact that their pain is often worse with damp weather or more likely to have pain radiating down the legs. Whereas with people with vertebral fractures, it's often quite a sort of a brief or momentary pain, and it improves on lying down. But there is no difference in the severity of the pain. So there's no point asking someone how bad their pain is, because that's not going to help you identify if they've got a vertebral fracture or not. And there's also no point asking them what they can't do anymore, because that's also not going to make any difference, because there's no difference in bothersomeness of the pain. So we know that people with vertebral fractures have pain. We know that where it is different and how they describe it is different. And then we did a focus group where we took people, women, who knew they had vertebral fractures, and we just asked them about their experiences of pain. And what I find amazing is that not everybody knows when their vertebral fracture occurs. I find that amazing because, as most of us will know, also it can be agony. It can be bang, sudden onset, agony, back pain, really shocking, tensely disruptive, so bad you get admitted to hospital, and yet some people don't even know when it happened. I do find that discrepancy really interesting. And so when we spoke to our focus groups, of those who knew when it happened and had this sudden onset agony pain, that lasted about somewhere between 1 week and 8 weeks. But everyone also described a lower level, dull, grinding, gnawing ache in their back. And everyone described that this pain gets worse with particular movements, and you can see some of the activities there. And in particular, washing the dishes seems to be a big problem. So I think it's what I call the position of work. It's when you're leaning forward doing something, and you're putting all of your weight on the front of your vertebral column. And people would describe the fact that their back pain starts and it builds and it builds, and they've got to step back and just take the pressure off their spine. And that's a very typical story. Other symptoms, I think it was our radiology colleagues who described a lot of these other symptoms, and this very blurry image is taken from the Royal Osteoporosis Society document on the management of symptomatic vertebral fractures. But it is not just pain. There's also shortness of breath. There's lots of impacts and thoughts, feelings and emotions with fear of falling, fear of further fractures, height loss, sleep disturbance. And then there are other risk factors that we can think about in our patient with back pain. We know that vertebral fractures increase exponentially almost with age and are more common in women. We know if you've had a previous fragility fracture, you're more likely to have a vertebral fracture. Steroids, we've already heard about being very important. And I think smoking is a particular risk factor for vertebral fractures, possibly because of the coughing associated with smoking in a thin, frail person. What about physical examination? Well, if you read the literature, there's loads of ways of looking at measurements of thoracic kyphosis. I quite like the rib to pelvis distance. Feel free to do it on yourself now. It's how many fingers you can get between the bottom of the ribs and the top of your pelvis, and you need to do it on both sides. And if you can get 3 or 4 fingers in, then about 3% of women, older women, they say, have a vertebral fracture. But if you can only get 1 finger, then approximately 12%. We've done some work looking at the wall to tragus distance, and the tragus is that little triangle at the front of your ear. And the bigger that is, the more likely you are to have a vertebral fracture. And then the acute vertebral fractures are tender to gentle percussion down the spine, whereas degenerative change is not. Now, unfortunately, we can't take a single one of those features in the history of the examination to decide who to do an X-ray on. We do need to combine these features. And that's the piece of work that I've been doing for a long time. And what VFRAC is a simple clinical checklist aiming to help us decide which older women with back pain should have a spinal radiograph. And we developed it using just over 1,600 women aged 65 to 97 years old who had had self-reported back pain in the previous 4 months. And they all had a questionnaire, physical examination, and a spinal radiograph. And we used logistic regression to identify some of the independent predictors. And in the end, what has come out is that this questionnaire has 15 quite simple components. I'll show you some of them in a minute. And it takes approximately 5 minutes to do. And it identifies over 90% of those with more than 1 vertebral fracture and about 60% of those with a single vertebral fracture. And considering we can only find about 20% at the moment, this is much better. Some of the positive predictors, the strongest one is actually a fracture after age 50. But then the second strongest one is agreement with that sentence that you can read, which comes directly from our qualitative research group. And the negative predictor, so meaning you're less likely to get a vertebral fracture, is if you describe your back pain as like a toothache, or if it's right in the low back or buttock area, or if you've got increased body weight. So it is available as an online tool, and we're just waiting, we need to get MHRA approval, which we'll be doing hopefully with a multi-centre study next year. We've also done some work in men, and there's no need to modify it, the tool. We've tried to work out if people could do it at home, because an appointment with a healthcare professional in primary care is very precious and very difficult to get hold of. And unfortunately, people seem to guess their height, weight, and water tragus distance, so we can't do that. But we may be able to do a sort of virtual method. And we've translated it into Urdu using a cross-cultural adaptation, and we've got little audio recording buttons where you can press a button and out comes the audio recording of the sentence, and we're currently translating it into Punjabi as well. We're testing it within primary care, and we're trying to work out how it fits in within pathways of back pain management, but also the IT systems. So I'm very much hoping that this is going to be available if the big study we're doing, hopefully next year, shows that it is clinically and cost-effective. So, summary. Think about doing a spinal imaging on those where you're suspicious for vertebral fractures, and I hope I've convinced you that there are features in the history and examination that mean somebody is more likely to have a vertebral fracture, and in the future we may be able to use the VFRAT tool to use an evidence-based guidance as to who to x-ray. But also think about x-raying where the presence of a vertebral fracture is going to change your management recommendations. If you're recommending somebody does not have treatment, you probably need to make sure they've not got a vertebral fracture, because otherwise it's a bit embarrassing. But also think about an MRI scan, as our colleagues talked about, if you are interested in the age of the fracture, perhaps because you're considering vertebroplasty. So very briefly, because a lot of this has been covered actually, I think we need to think about how we're going to measure, how we're going to manage vertebral fractures. I think, I don't need to say this actually, because I think we just need to set up a pathway. I think one part of the pathway that I've a feeling there's not been, or there might need to be a bit more emphasis, is about self-management and guiding patients to help themselves and work out how they should eat, how they should live, and healthy living and for strong bones. And just a little bit of a plug for the Royal Osteoporosis Society. There's so much on this website, including a dance video developed by the Royal Scottish Ballet for people with osteoporosis. So in summary, I would say vertebral fractures are common and often missed, and they can only be identified if we image the spine. Please do spinal imaging if there are features in the history and examination, or if the presence of the fracture will change management. And then I think for me, thinking about what you're going to do then with a pathway for the holistic management of people with vertebral fractures is absolutely key. And I think it's going to become increasingly important over the next 5 to 10 years, because it is likely that machine learning AI approaches to automatically identify incidental vertebral fractures from CT scans are going to become part of our normal secondary care, and we're going to become swamped with referrals from these vertebral fractures. And so we need to set up the pathways now so that we know how to deal with them. Thank you very much.
Thank you very much indeed, Professor.